Hello everyone, welcome to this video series steered by Dr. Amdekar's team. I am Dr. Tushar Maniar, pediatrician from Andheri, and I'll be talking on approach to bony deformities. Whenever we have a child or an adult with a complaint of bony deformity, the first thing we want to make sure whether it is really bony or otherwise. As we know, more commonly we have joint involvement, arthritis, swelling of the joint itself, which may look like a bony deformity, and we are not going to discuss that today. So what are the other deformities which will look like bony deformity but are not? A classic example is in a newborn, when they come with swelling on the head, it is actually a caput succedaneum or a cephal hematoma. And then parents worry that there is some kind of damage, fracture, bone swelling, etc. And we need to make sure that this is not a bony swelling. Once we have decided that this is a bony swelling, we need to make sure whether it is physiological or pathological. So what are the physiological bony deformities that we come across? I think the most common deformity that we come across is bowing of the legs. And as we know, the child normally has bowing of the knees up to the age 2 years and sometimes even up to 3 years. Now, it is physiological unless it is asymmetric, it is very wide, or if there are any other red flags associated with it. Now, as the child grows beyond 3 years, they normally develop knock knees, which get corrected on their own by 7 years. So from 3 years to 7 years, we may have parents coming with concerns of knock knees, which are actually physiological. Similarly, a newborn who is lying continuously on the bed will develop a flat occiput, and that is considered normal. Once the baby starts sitting, things will settle down. We have to also now see whether this is a localized problem or whether this is a generalized problem, whether this is an acute problem or whether this is a long-standing problem. So when we talk about localized problems, the commonest thing that we think is either it's a callus formation following a fracture. Also, it could be a malunion. And finally, it could be something ominous like a bone tumor. When we are talking about generalized condition, we have to see whether this is happening, the bony deformity is restricted to only one area or it is involving multiple areas. Classically, if you see child with skeletal dysplasia, you will have multiple generalized bony deformities. On the other hand, you can also have metabolic bone disease in which the weight-bearing areas will develop bony deformities, classically being rickets. And there are certain conditions in which the bone is abnormal and there are pathological fractures which will heal not necessarily in the correct manner, and one could be left with multiple deformities. Once we have thought about physiological or pathological, we have now decided whether it is localized or generalized. The next question comes to our mind is whether this bony deformity is a bony problem alone or whether this is part of something larger. That means this is a manifestation of some other systemic condition. The classic thing is, again, rickets we need to look out for, and if it's nutritional rickets, it may be limited to bones. But if we are dealing with some other non-nutritional rickets, there could be involvement of other organs, things especially like kidney. It could also be a manifestation of mucopolysaccharidosis or conditions like osteogenesis imperfecta. We have now to think about whether this problem could be a potentially serious problem. Classically, if you have a cervical rib, then that could lead to thoracic inlet syndrome, and that could be a problem. The other major issue is if the child has a bony deformity on the back in the form of a gibbous, it could be potentially life-threatening or definitely could lead to some neurodeficits in the lower limb or bladder and bowel. We have to also think about the etiology of the bony deformity. We have already talked about metabolic bone conditions. We can have sometimes endocrine disorders, for example, McCune-Albright syndrome, which can present with painless bony swellings at the end of the bones, and they can have precocious puberty and some skin lesions like Caffioli spots. It could be a manifestation of a larger neurological condition, like we see pes cavus in Friedreich's ataxia, or it could be a pectus excavitum as a part of syndrome like Marfan syndrome. We should not forget that there are certain malignancies which can present as bony swellings, and of course we have to think about primary bone problem like skeletal dysplasia. We should also now look at some of the common conditions that affect different parts of the body in terms of bony deformity, classically being skull deformities. The newborns are born either sometimes with a dolichocephalic skull or a brachycephalic skull. They can also have frontoparietal bossing because of rickets, and sometimes because of extramedullary hematopoiesis. In children with thalassemia, there could be a hot cross bun kind of a shape. Also, if the child develops craniostenostosis, it could be a potentially life-threatening problem because of the raised ICT in a growing brain. In the chest, it could be a pectus excavitum, or in the spine, it could be scoliosis, which could be standalone scoliosis, or it could be a manifestation of certain other muscle disorders, in which it could be a late manifestations in case of Duchenne muscular dystrophy, which in the earlier stage can also present with lordosis combined with scoliosis. We should not forget any pain or swelling over the spine as a possible tuberculosis of the spine. In the lower limbs, we already talked about bowing and knock knees, but there can be other manifestations like double malleoli and other bony swellings, or even painful tender bony swelling in certain athletes, where you can have in the foot. There is a common confusion between congenital talipes equinovarus or clubfoot as it is known versus metatarsus inversus, where this is a self-limiting condition, whereas in CTEV we need to make sure whether it is just a positional CTEV or if it's a neurological CTEV, because neurological CTEV, as we know, is associated with other malformations and it could be a manifestation of certain other diseases. Friends, when we look at multiple bony deformities, we should pay attention to the pattern of involvement. Sometimes that gives you certain hints. Suppose there is a bony involvement of the end of the bones in the weight-bearing area, then you will think more in terms of rickets. But if these weight-bearing areas, rather than being wrist, is now affecting the knees, the lower limbs, then you would think that this disease onset was later than 1 year, and then you will start thinking in terms of non-nutritional rickets. Sometimes it will be difficult for us to pinpoint a pattern. That means there can be certain bony deformity, especially fractures of different timeline or in the area which we normally don't associate with. And here we should think about non-accidental injury or child abuse as it was known earlier, and we should take appropriate steps for child protection. So let me summarize that whenever we have a bony deformity, we must make sure that it is bony, check whether it is physiological variation or pathological. We need to look at whether this is localized, generalized, or is it a potentially life-threatening or major problem? Is it static or progressive? And whether we can identify the etiology by looking at certain patterns and features of that bony deformity. Thank you, friends.